Tendon rupture. I will not go through point by point the exercise program. The exercise program that Katarina Nilsson Helander had in her RCT has been accepted for publication for American Journal of Sports Medicine, and this past Friday it was on preview online, and on there is the specific treatment protocol that we used in her study, if you're interested. I want to talk about the rehabilitation complications. So as a physical therapist, the complications that I focus on is that the recovery takes a year or longer. And patients avoid returning to sports due to fear. We see deficits in strength of up to 10 to 30% that appears to become permanent. Gait abnormalities have been found 24 months after injury. We see, described in the literature, difficulty with tendon elongation. That means the tendon heal in an elongated position. And the other problem we see, there's large variations between patients, regardless of treatment. That means regardless of surgery and non-surgery, some patients do really well and some patients do really poorly in relation to function. But why is then rehabilitation as exercise important? And as I mentioned before, the tendon needs to be exposed to load during the healing to improve tendon structure. Increased physical activity gives larger and stronger tendon calluses, and higher physical activity has been associated with a more mature tissue repair. However, starting exercises early for tendon ruptures has been often avoided because we have a fear of the re-rupture, which has also been our main outcome up to this point, and we had a fear of tendon elongation. However, I would like to emphasize that early rehabilitation and mobilization results in a decreased risk of re-rupture, just as Katarina Nilsson Helander mentioned. Early rehabilitation and mobilization results in less tendon elongation. However, we need to understand how the exercise affects the tendon, basically what I would call rehabilitation theory, to avoid the overloading, but also to avoid underloading. So just to reiterate, I think it's important to realize when you rehabilitate tendons that you can increase the tendon load in two ways, either by increasing the external load or by increasing the speed of the movement. So to progress the exercise load, often when we discuss exercises and I say, I think you should start with a heel rise right away, maybe right after surgery, then people think that the heel rise means you're standing on one leg and go up and down, but you can actually progress the load fairly simply. I mean, a sitting heel rise exercise can use just 5 kilos or 10 kilos or not have any weight at all, just getting the motion. You could increase to do it on 2 legs, you can do it then on 1 leg, or have eccentric overload. However, then it's important too that the speed of movement really matters. So do slow and controlled heel rises compared to hopping, and hopping is like jumping rope. Hopping, you still use the same body weight, but have up to 5 times the body weight loading in the Achilles tendon. So the other thing we talk about early mobilization, but if you look at the treatment protocols that's out there, the early mobilization usually means that the patient get one of these orthotics and start walking, either active motion to walk, but still we have been very limited in the rehabilitation as far as exercises the first 6 to 8 weeks. And for me, I start usually then with the rehabilitation somewhere 6 to 8 weeks, the patient comes to us. And the difficulty we see during the whole rehabilitation is that they have strength deficits, but they also have a disproportionate weakness in the end range of plantar flexion, meaning they can't go as high up, the heel can't rise up as high as the healthy side. And this is the clinical presentation when I look at my patients. I usually see a medial gastroc atrophy, and as I said, they can't come as up high, standing up on the toes on the injured side. And based on the studies that we did with Katarina Nilsson's RCT, these we're looking at, so how do we recover? And we usually compare the injured side to the healthy side. And when we look 12 and 24 months afterwards, we have not recovered how high we can go up, the heel rise height, or the muscular endurance when we perform the heel rises. And actually 2 years after injury, only 32.5% of the patient had achieved normal function. Usually what we use for ACLs that they need 90%, within 90% of the uninjured side. The other thing, as I mentioned before, and with this picture what I want to illustrate is that regardless of surgery and non-surgery, some patients have full recovery of heel rise height, and some patients have as low as 50% on the other side. So regardless, some patients do really well and some do not. And it makes me feel that at least there should be a possibility to get everybody up to achieving 100%.